Wonderful. Okay, thanks, Tim, for getting things opened up, and welcome everybody. Glad to have you on. We're going to get right to our speaker in just a second. A couple of quick announcements as you're coming on. First off, wanted to make sure that we gave a shout out as we wrap up the Distinguished Speaker Series this year of our upcoming speaker series. So we have 4 fine folks that are coming on in the coming year, 2023. So Alyssa Lanzi will be one of our distinguished speakers. Jacqueline Loris Gore will be a second distinguished speaker. We also have Nidhi Mahendra and Roberta Ellman. Those 4 have been recognized by ASHA and all of us for all of the wonderful work that they've done. And we look forward to hearing from them in 2023. So that will be upon us before we know it. So looking forward to those 4 folks being with us. Second thing, make sure if you haven't yet, if you're considering the summit, we hope you'll come to Raleigh, North Carolina for the Leadership Summit, March 23rd through the 25th. That will be a chance for us all to be together in person. So looking forward to that, and looking forward to seeing all that the wonderful Triangle area has to offer, and seeing you all. So with that being said, I'm going to go ahead and introduce our distinguished speaker. Most all of us know Jackie Hinckley. Jackie is a professor at Nova Southeastern, has done an amazing amount of work in her long and illustrious career with people with aphasia programs. Started out up in Michigan, ended up in a little warmer area down to the south. And Jackie has really led the way in involving people with aphasia in research, in programs, in program development. And so it is our very strong fortune to be able to listen to Jackie and learn from her. So with that being said, Dr. Hinckley, I'm going to turn it over to you and your presentation. Jackie will present for about 20, 25 minutes or so, and then we'll have some time for conversation. So just like we've done in the other series, we'll ask that you hold your questions until there's a time for questions, and the same in the chat. It's really easy to put a comment in or to add something, which is all wonderful, but it can detract from the speaker. So all eyes and ears are on Dr. Hinckley. So with that, I will turn it over to you, and thank you very much for being part of this Distinguished Speaker Series.
Thank you, Tom, and many thanks to Aphasia Access for inviting me. I'm really happy to be here and humbled to be included in the series. I really puzzled, I shouldn't say puzzled, but I really thought long and hard about what I wanted to speak about today. I thought that, having this opportunity to be with my colleagues who are members of Aphasia Access is such a special time to talk about ideas and to start thinking at a higher level than some of the times when we just have presentations and we don't have as much time for discussion. Here today, we actually have plenty of time for discussion if we choose. So in that spirit, I definitely wanted to kind of follow the format. And before I begin on the topic today, I certainly wanted to provide my disclosures, but I also wanted to acknowledge so many people who have influenced my thinking on so many of the ideas and concepts that I'm going to try to weave together today. And there's so many of them, I can't possibly list them on this slide. And but many of them are probably here and also members of the Project Bridge Advisory Board, but other people as well. And I thank you for being who you are and for the opportunity to know you. I was really excited to be invited actually at the end of the year. Todd knows that I kind of said, wait a minute, is anyone going to come on December 19th? I mean, there's holiday shopping to do or whatever. But I'm actually really excited about this time of the year. I think it's a time that we all naturally reflect on the past and think about good things and things we might like to change, and look forward in anticipation and excitement to what's coming. And I want to weave that into the talk today, or discussion today, I should say. I'm not planning to bring any ghosts of the past or present or future along, at least I don't know, sir. Maybe I
Join
will.
the meeting.
But anyway, so let's move ahead. I want to start by kind of starting with the past and a time in the past when I was looking to the future. So in 2015, I was honored to be asked by our dear, dear mentor, friend, and colleague, Dr. Audrey Holland, to write a piece about what aphasia practice would look like 10 years from then. So this was published in 2016. And so it's looking ahead to 2026. And we still have 2026 in our future. So we still got a couple, 3 years where, you know, if there's any recommendations in this paper that any of us still think are good, we still have time to get there. But thinking ahead to 2026, one of the things I think is important to our audience here is that in that year, the publication of life participation approach in aphasia, you know, that'll be about 25 years old. Wow, that'd be a great time to celebrate. Maybe just as a note, maybe Aphasia Access should really celebrate that. But thinking ahead, 2026, that's where we're at, you know? And so when I wrote this piece, I got input from a group of people, various people with aphasia, and also from founders of an aphasia advocacy organization. So I would not say that this article was co-developed, which is the term I used in the title of today's topic, because I got input and then I sat down and wrote the piece myself. So we did not co-develop the piece, but I definitely listened and changed some of the content that was included because of getting that input. So here is the dictionary definition of co-development. It's a very simple definition, the process of developing something new together with one or more other people or organizations. But we all know that actually that's pretty complicated, and a definition or a description that's more specific to healthcare and healthcare research, for example, calls co-development a fluid and evolving process that is the outcome of shared decision-making. And I think that starts to grasp at how complicated and what a process it is. It's really a relationship as we engage in co-development. Well, I want to get back to the future, I guess, and I want to share with you a few of the themes that I wrote about back in 2016 when I was imagining where we would be in the world of aphasia in 2026. And here are 4 of the main themes that I wrote about. One was when it comes to intervention and services, I imagined that we would have many more effective therapies, that therapies would continue to be developed, and that there would be more participation approaches, especially in acute and inpatient hospital settings where I think, at least at the time, I thought lacked participation models the most, but really that there would be more participation models across the board. I also imagined a world where communication partner training became routine. A second theme that I talked about was more person-centered care, and in particular, incorporating the ideas of aphasia identity and personal factors, and that the more we incorporate that, the more person-centeredness should hopefully emerge. One of the things I wrote is that a more futuristic, advanced view of person-centered care will include determining the client's values and preferences prior to any formal assessment, and allowing those priorities to dictate goals and outcome measures. A third theme I wrote about back in 2016 was that technology would really play an important role in 10 years' time. And one of those, of course, would be telehealth and providing teleservices of every kind, and also creating a more communicatively accessible environment. And the fourth theme was really about professional development and training. And what I wrote about in this paper was that there would be a growth or a development of competency-based professional development. Because for a long time now, we know that didactic training only increases knowledge, but not necessarily action and behavior. And so I imagined that we would incorporate more competency-based or skill-based, experiential-based training in our professional development. So now here we are in the present in 2022, and I sorted these themes in 3 simplistic categories. Yes, we are on our way, maybe, and not so much. And I know we're going to hold our chat discussion, but I'd love for you to write some notes on the side that maybe we can discuss in a few minutes about whether you agree with my assessment here. This is just my personal idea about it. So one theme that I wrote about was that there would be more therapies shown to be effective and a wider variety of therapies. And I think that's most definitely true. We have so many exciting interventions for things like friendship and psychological and psychosocial interventions, along with other interventions that have been developed and are developing right now. So that's definitely the case. I have a little question there, though, for all of us to discuss. But we have a lot of effective therapies. Do we use them? Are people having access to them? That's a little side note. And then another thing I think we're definitely on our way is technology. Partially thanks to COVID, but we have so much more telehealth, so many more online groups and services. And actually, even before COVID, we had the Aphasia Recovery Connection doing a fabulous job moving online groups and so forth ahead. So we definitely are doing great with that. I hope you agree. And also that just because of technology and because everybody, regardless of their communication ability, is using a number of different ways to communicate. I don't know how many times I send now emails with just an emoji. And I think we're all doing that. So there are more communicatively accessible environments thanks to technology. Now, in the maybe column, I wrote more participation approaches. I think, yeah, but just doesn't seem as much as we want it to be, right? So I put it in the maybe. And all the same way for communication partner training. I think that they're probably, although I don't really have any data for this, but just my gut feeling and talking to people, I feel that it does happen more than it did in 2016, but I'm still not sure it's really where we want it to be. So I stuck that in the maybe column as well. In the not so much column, I put more person-centered care. And here, and I'm going to show you why I put that. So one of the things I also did in preparation for today's talk was to get some input from people with aphasia. And this is non-scientific input, but nonetheless, it's very important input. And I asked the very big community of Aphasia Recovery Connection, how can speech pathologists make the world better for people with aphasia? And what do you wish speech pathologists would do or start doing? Think big or small, think radical. Now, at the bottom of this slide, you see a video link, which I will put in the chat at the end of my talk. And it's a YouTube of a video of a discussion of this question that Carol Dow Richards, who I believe is here, led. And I urge you to take the time to watch that video. It's 30 minutes long, so I didn't have time to play it here. But I've written some notes about it. And I hope that when you watch it, you feel heartbroken too. I think we need to feel heartbroken about many of the things that came out when asking people with aphasia this question, which I have at the top of the slide. So here are some notes about things that people said, not just in the video, but also on Facebook. And I went through all the comments. And one was teletherapy, that there needs to be more access to services for people living in rural communities. But people said there needs to be a person-centered approach. There needs to be family education. Could you please just talk to me? Could you please just engage me in conversation? Think outside the box. And by saying that, I believe the person meant, don't just hand me a worksheet. Another person said a sheet of paper did nothing for me. So another comment, including the family and therapy, came up multiple times. How about this one? Write functional goals. The example that was given from a caregiver was that their family member with aphasia was bad at confrontation naming, but got better at everyday communication, but there wasn't a goal for that. And so that affected the continuation of the services. How about the person who said, I can speak pretty well. I wanted to work on reading, but she wouldn't work on reading. Now, yes, this is just a sample and it was on Facebook, but the reason I put a lot of stock into these comments is because I feel that I have been hearing these concerns and issues my whole career. And that it really doesn't seem to change that much. Now, I don't have any numbers for that, but I just keep hearing this over and over and over. If any of you were at the ASHA convention where I had the privilege of presenting with Trish Hambridge and Denise Lowell, you heard Denise tell the story of one of her therapists, and this is in the last year or two, working on zoo animals with her. And in Denise's words, as she described it, she said it was a very nice lesson about zoo animals. But my children are grown. We don't go to the zoo. I'm not going to work at the zoo. Why am I working on zoo animals? We hear these stories over and over and over. And I want us to think, what can we do about this? We need to maybe think somehow differently. And I'm here today to think about this with you. Looking at the notes that I wrote from all the comments and the input that people shared, I really feel like it boils down a lot to person-centeredness. And we can talk about person-centeredness and life participation approach in various ways. And I want to drill down into this a little bit more. So let's look back at the list that I made. And again, you might not agree with me, and that's fine, and let's discuss it. When I look, I had these columns of yes, maybe, and not so much. And now look at the same slide when I asked the question, in who has the most power to affect the change in these areas? And once again, please write down some notes and think about this so we can discuss it. Under the yes, what was in the yes column was the number of therapies that are being developed and technology. And what I'm suggesting is that who has the power to accomplish that? Well, I would say researchers and systems. And when I say systems, I mean funding systems. So researchers and funding systems work together to develop new therapies. I also mean legal systems and policy systems and healthcare systems, because really it was due to legal issues, changes in regulations, and also healthcare systems that drove a lot of changes in telehealth and other things, especially in response to the COVID pandemic. So I think those are drivers in our yes column. In the maybe column, I think that the main drivers are clinicians. I know we're all clinicians. Just to say clinicians is very simplistic, because clinicians are working in a very complicated system regarding reimbursement and policies and all kinds of things. But if we identify a group of people who are the main drivers, I'm going to say clinicians. And then in the no column, we had person-centeredness. And I think this is really fascinating, because when we talk about person-centeredness, we're really talking about shared decision-making, giving the client a voice, honoring what they want to do and what's important to them. You know, the gentleman who said, I wanted to read, but she wouldn't work on reading, right? When we're talking about person-centered care, it means we have to give some of the power that drives to that client, to the person with aphasia or their family member. And that, to me, is the area that's not happening. We're not making good progress on this relative to other areas. So I really want to zoom in and think about this issue of shared decision-making. Now, shared decision-making, of course, the minute we say shared, it's not completely the client who can drive this. Obviously, it's a team approach. We need the clinician or at least one other person. But it's a matter of shifting or sharing the power, right, with the client. So let's think for a minute about shared decision-making. And what I want to propose to you today is that shared decision-making is the most fundamental thing in treatment, in co-developed research, and also possibly in public awareness. And again, these are a bunch of ideas of mine put together because I figured this is the forum to discuss it, right? So I want our discussion. When we say co-developing, like I did in the topic for today, you know, that is a very complex process. And as you see in the quote at the top of this slide, it's a complex set of psychological, social, cultural, and institutional interactions. It's not simple. And I think that our skill and ability in shared decision-making is again the foundational component for all these things. So let's explore each of them a little bit. Let's start with treatment. I think that everybody, all of us Aphasia Access members who are here today, probably would endorse this statement that every treatment session should be, in a sense, co-developed, right? That there should be shared decision-making. And we know that collaborative goal setting is an evidence-based practice that is very effective. And an example of that is goal attainment scaling, that there should be shared decision-making on treatment choice and effective education and counseling, involvement of family, and that we want to do things, even the smallest of things, like what would you like to work on today? That, you know, we've worked on this or this, what's your choice today, etc. Even these small things foster agency, self-efficacy, and self-advocacy. So just a thoughtful question or a discussion question for later: is shared decision-making a core component of LPAA? A core component means that it's a basic component that is, you know, a minimum requirement. And I'd like for us to be thinking about that. Now, I think most people here know that stakeholder engaged research is near and dear to my heart, and it means involving the people who are going to be affected by research into the process as true collaborators. all the steps in this also require shared decision-making. So when we have true collaborators, we identify research priorities together, co-create research questions, determine meaningful outcome measures together, discuss the implications of the results, and generate the dissemination plan for multiple audiences together. This is what a true collaborative, stakeholder engaged research process looks like at the highest level. But I think one thing that we have learned through Project Bridge, which is a research incubator for this kind of research, is that each of these steps and many more, including how are the meetings going to go, when are we going to meet, every little thing in this process is really a process of shared decision making. And in 2018, when we first had our Bridge conference, this really came into sharp view because we had researchers who were also clinicians, and I think some of you are here at that meeting, who were meeting now around a round table with people with aphasia and family members and clinicians. And the clinician in us kicks in a little bit, and all of a sudden we're deferring to those people with aphasia around the table instead of realizing that we have an important role too, and there has to be a balance. This is shared decision making. When we learn and we know how to engage in a true collaborative partnership. As a little example, I just couldn't resist putting in this quote, which is not to do with aphasia research, but this is a patient stakeholder who was in a research group and who said the reason that we chose the researchers to work with that we did, we actually interviewed a whole bunch. One of them came in and I had a conversation with her and I said, how do you feel about partnering? And she said, no. I said, no, well, why? What is that? And she said, because I know nothing about American Indians. That was a relevant issue in this project. Nothing. And I really feel like you've got to know something about this population. I have nothing to offer. And I said, we'll take you because we know nothing about research and we're coming in at the same place in some ways. And we'll listen to every word you say and you'll listen to every word we say. You're not coming in with preconceived notions, and we'll have this co-learning going on all the time. I think this is a really insightful and meaningful description of a true collaborative partnership, and that also really leads to probably shared decision making. Now, I just want to say a quick word about aphasia awareness. It's not really my main topic here today, but I think that increasing public awareness of aphasia also takes shared decision making and is probably most effective when that is the case. I just had to set this in because I couldn't let 2022 close and this opportunity to speak without highlighting the amazing accomplishment that has been made in 2022 around aphasia awareness in the public. And in 35 years of my career, awareness and knowledge of aphasia has been right around that 10% mark and really never varying much. And this year was a big year for aphasia. And we have many people in the news and so forth going on. And I just want to encourage all of us here, just as a little side note, to embrace those opportunities, but also when a person with aphasia is in the public eye, I think we need to have compassion about when and how they want to disclose their own experiences. Sometimes I think in our private conversations among ourselves as speech pathologists, we're so eager for things to change in the public eye for aphasia that we forget we're talking about a person who has to make a personal decision about when is the right time for them to talk about any disability issue. But anyway, I just wanted to certainly celebrate that as something in 2022. So let's say, what is shared decision making? Now, shared decision making, especially in the medical literature, is usually talking about, which treatment would work best for you. But there's so many other things. This is a much broader concept. Shared decision making involves a relational aspect as well as the content aspect. So it involves two different people. Usually in the medical literature, it's defined as one patient, one healthcare provider. But my version is two people in different roles and who may have different status. So when any one of us is a patient, and I'm sure many of you have had this experience, when I'm the patient, I definitely feel it that I have a different status sitting in that appointment than I do when I'm the therapist. So anyway, I would say it's two people in different roles, and both parties are active participants, share knowledge, share values, share responsibility for the final decision. In healthcare, shared decision-making is indicated in most chronic diseases, and that would apply to aphasia. And it's associated with increased autonomy, control, and individual competence on the part of the patient. My version is saying that that applies to the person with the less power in the relationship. Now, this is not, I'm not intending to really talk in detail about shared decision-making, the nuts and bolts of it today, but I did want to show you one way of operationalizing shared decision-making. This is a questionnaire called the Shared Decision-Making Questionnaire, and it's in the literature, and I do have references at the end that I'm happy to share, or maybe there's a way for me to share my slides too. And you see the kinds of questions, and these represent the core of shared decision making. My clinician made it clear a decision needs to be made. And really, more than that, made it clear that I can participate in the decision. My clinician wanted to know exactly how I wanted to be involved in making the decision. Some people don't. They just want to be told, that's okay, we have to figure that out. The person has to be given that choice. My clinician told me there are different options, explained the advantages and disadvantages of the options, helped me understand all the information, asked me which option I prefer. Look at how detailed this is. It's not just about giving the options. It's then the next step of asking which one I prefer. And together, collaboratively, we thoroughly weighed the different options. We selected an option together, and we reached together an agreement on how to proceed. Now, the same questions are also written from the point of view of the clinician to fill out. So I just wanted to give you a feeling for really the granular level. What does shared decision making look like? I realize that this questionnaire is definitely written for physicians, and that in aphasia, it's not just about treatment options. There's many other questions that we might be asking, like collaborative goal setting, like what's important to you to work on today? What kind of home practice do you want? Let's talk about your discharge plan. There's many other things that we would be talking about, and it's not just treatment A or treatment B. But I just bring this up because it's probably the example that seems to be very more common in the literature. This is a model of shared decision making, and I don't want to get into the details of it. I like this one because it's based on actual encounters. And I just want you to get a feel for the sense that there is knowledge about shared decision making and how to go about it and what kind of supports are needed. Ora Kagan did a beautiful presentation at, I think it was the last Distinguished Speaker Series on treatment aids and decision-making aids. And of course, Ora and the Aphasia Institute have fabulous supports for decision-making. But that is one part of this whole process. The whole process is really relational training as well. Now, again, there are shared decision-making trainings that are out there, mostly oriented to physicians. I will say when I did a quick search, and if you know of something, a resource on shared decision-making in speech pathology, please, in a few minutes, you can share that in the chat with everyone, and we might be using a different term. But if I search shared decision-making for a quick search in speech, I don't really find anything. So we don't have any tools really like these yet that I could find. Please, again, correct me if I'm wrong. But what I want to say is that shared decision-making, I believe, is fundamental to effective treatment, collaborative research, and even possibly public awareness campaigns. That people with aphasia and their families continue to identify a lack of shared decision-making in their treatments. Shared decision-making is an exercise in power dynamics. Who has control? And we do have some understanding of the process of shared decision-making in healthcare environments, and there are training approaches that have been shown to be effective. So now let's turn the rest of our time and our thoughts to the future. When it comes to research, are researchers implicitly trained to avoid shared decision-making? I think that researchers are often trained to collaborate with other researchers, other people who they perceive as similar status to themselves. But I can say for myself and many people I know, and based on interviews we did around Project Bridge, mostly people don't have this kind of training when it comes to research. And what is the impact of our current traditional research system on the lives of people with aphasia? Let's think, though, mostly about the future and our clinical services. Do we do enough to train shared decision-making in aphasia? Do we train it explicitly with steps? I can't say, I'm sure I must have intuited it or absorbed it somewhere along the line, but I can't say that I ever got explicitly trained on shared decision-making. If we did do it, would it improve all kinds of things, including collaboration? Is the apparent lack of shared decision-making experiences reported by people with aphasia due to a potential lack of training, or system barriers, or a combination? Is shared decision-making the most fundamental aspect of LPAA? If it is, then would increasing shared decision-making in aphasia practice also spread LPAA? And just as a little teaser, I can't help talking about the tipping point. If anyone's read that by Malcolm Gladwell, and the idea would be, my question is, how can we get to the tipping point for real person-centeredness in practice? So let's talk about that. So I think we're ready for a conversation. Is shared decision-making a skill that is required for a co-developed future?
So with that being said, Jackie has laid the gauntlet for about 4 days of discussion here.